So the topic today, health symptoms you should never ignore. Our bodies are quite complex, and there'll be times when one feels something is not quite right. I don't feel well. And often this is taken care of at home with a couple of pills or some home remedies. However, there are certain medical symptoms that should not be ignored. Needs more attention. And how does one know when to seek medical help? Our speaker today will highlight certain symptoms that need further investigation. And there are, of course, many more. Dr. Zubina Mawji is a board-certified internal medicine physician. She has held leadership positions in medicine and administration, has practiced in the US, and now practices here in Toronto. She has lectured, taught, and published on many topics in medicine and women's health. Dr. Mawji believes in a comprehensive approach to global health and health education. She enjoys speaking and teaching on many topics, including empowering patients to understand and manage their health through healthy lifestyles and learning how to navigate the healthcare system. And she is a popular speaker in the community. And with that brief introduction, I welcome Dr. Zubina Mawji. Over to you, Dr. Mawji.
Thank you. Assalamu alaikum. And thank you, Nasmal Bhai and Bashir Bhai, for hosting Baraza, and looking forward to talking to everyone today and fielding your questions at the end of the presentation. So thank you. I'm going to share my screen here. We'll get started. So symptoms you should never ignore. How's the audio? Are we good?
You're good.
Yeah, okay. Symptoms you should never ignore, or Baraza Mini Medical School, as I'd like to call it. As was mentioned, we're going to talk a little bit about a couple of medical diagnoses today and a couple of the symptoms that you should look for, but there's so many more topics we could cover. I've only chosen 4 today. So let's go ahead and get started. You're going to be the doctor today, and that's why we call this mini medical school. You're going to find the diagnosis. We'll talk a little bit about treatment, but not so much. We'll talk more about prevention of some of these issues and about detection. And that's where you're going to be looking for the diagnosis. So we'll cover sudden symptoms today. We'll cover unexplained symptoms, and we'll cover persistent symptoms. And to start with, we're actually going to start with a little poll or a little examination or test. So if we could get the first question up. 65-year-old man sitting next to you in the mosque, having trouble eating biryani. He can't drink his soda without dribbling it down his mouth. What should you do? And this is a sudden symptom. A, call his wife. B, call his daughter. C, call his doctor. D, call the mukhi. Or E, call an ambulance. If you could use your devices to answer those questions. And answers are coming in as we speak. Great. So there was 1 answer for call his doctor, and 5 out of 6 answers, 83%, for call an ambulance. So that's pretty good. So let's talk about that a little bit. Let me see if we can get rid of that. There we go. All right. So this was the question, what is happening? And most of you accurately said, call an ambulance or call 911. And that is the most correct answer. Because what we're talking about here are signs of a stroke, things not to ignore. These are sudden symptoms. I'm going to introduce you to the concept of be fast, B-E-F-A-S-T, and calling 911. So some of you will actually have these iPhones, I think maybe iPhone 12, for example. And if you actually click both of the buttons, one on each side, what will come up is that screen that you see at the bottom there or in the middle, where actually allows you to call 911 right away. It's the emergency SOS button. But whether you have that or not, you can certainly dial 911. And that's really the moral of this. Be fast. When we think about how we spot a stroke and the warning signs of stroke, balance. So someone may start to feel a little wobbly. They may actually walk not balanced and may even veer off to one side. Their eyes, they may experience some blurry vision. They may start to have some drooping of one side of the face. And when we talked about the gentleman trying to drink his drink, he wasn't able to actually do that because his face was drooping. That's the F for face. Arms, there may be arm or leg weakness. Speech, there may be slurred speech. And lastly, the T in Be Fast is time. Time is brain when we talk about strokes. So this is a busy slide, but what I want you to pay attention to is this green circle in the middle. And this is the brain and how it's innervated. When we're dealing with a stroke, as opposed to something like Bell's palsy, the individual will actually have weakness on the lower side of their face and their mouth will actually droop. They're still able, because of the way the nerves work to the face, they're actually able to raise their eyebrows, okay? Whereas in Bell's palsy, the entire face droops, the eye droops, the lower face droops, and they're unable to wrinkle their forehead. So if you're looking at someone who actually has had a stroke, this is what they're going to look like. Their eyes will be fine, but it's this lower part of their face. Okay. I'd like to move on to case number 2. If we could have the next poll come up. So last night, your wife was discussing redecorating the house when suddenly she started talking about the Prime Minister and the trucker situation. She doesn't remember where she is, thinks it is morning, and then remembers you forgot her birthday and Valentine's Day. So what would you do? Would you call her mother, call your kids, call her doctor, take her to buy that Valentine's Day gift, or take her to the emergency room?
I'm actually going to relaunch the poll because they need time to respond. Okay.
There we go. Thank you. And the answers are coming in.
Almost there, 9 out of 23. 10 out of 23. Okay. Shall I share the results?
Yes. So 73%, 8 out of 11 of you would take her to the emergency room. 1 would call your kids. 2 would call the doctor. And no one bought the Valentine's Day gift. All right. So what we're talking about here is an unexplained symptom. So we talked about sudden symptoms with a stroke. Now we're talking about unexplained symptoms. And I would say here, the most correct answer is probably E. Take her to the emergency room. Some would call the doctor, and I think that that's potentially a reasonable answer. But what are we actually looking at here? We're looking at a condition called delirium. Many of you may be familiar with the term dementia, but we're talking here about delirium. And delirium is important to understand because it's a change in mental status that's sudden, unexplained, and often comes and goes. So a person may be fine for an hour, and then an hour later, they may start to have some of those symptoms that were described in the case. There are lots of different causes for delirium, but some of them that I've listed there. A sudden stroke can do it. Infection, probably the number one culprit we see, either due to pneumonia or to a bladder infection, urinary tract infection. Medications can do it, so a change in someone's medications. Coming off a medication or stopping a medication abruptly can do it. And certainly head trauma or brain tumors. And there are a host of other causes for delirium. So with delirium, sometimes you'll see patients seeing things that don't exist, like hallucinations. They'll be restless, they'll be irritated, they may get very angry, they may call out or moan, make other types of sounds, and then they might get very quiet and withdrawn. So again, these symptoms wax and wane. And especially in older patients, we'll see more of the quiet or the withdrawn type presentation. A patient may feel very slow. They may not be moving around as they normally would, very lethargic, trouble with sleep, either trouble getting to sleep or staying asleep. And they may want to sleep in the daytime and then be up at night. And that's the disturbance of the sleep-wake cycle. So this is another example of what we see when we see delirium. So we see someone getting more agitated and then more withdrawn and then a little more agitated, and it kind of goes on. So when you see this pattern, you're looking at more of delirium. Unlike dementia, which is a much more slower, progressive change in mental status that happens over time and much more subtle. And certainly dementia is a topic in and of itself that we could spend over an hour plus talking about. All right, we're going to move on to, we talked about sudden symptoms, we talked about unexplained symptoms, and now we're going to talk about persistent symptoms. So if we could have the next poll. Your brother-in-law can't go on walks with you anymore. He has pain in his legs below the knees in the back of the calves. Your wife, his sister, told him to use balm and wrap his legs because it might be a heart condition. What should you do? A, take him for a walk anyway. It will get better with time. B, take him for a leg massage. C, take him to the doctor. And D, take him to the emergency room. And the answers are coming in here. We've got a very strong medical school class. So we're at about 13 respondents, and 9 out of the 13 of you take him to the doctor, and 4 out of 13 answered to take him to the emergency room. Great. So let's talk about that a little bit. All right. So with this question, I think understanding the difference between emergent and semi-urgent is important. And what I mean by that is it may be acceptable to take him to the physician depending on how quickly you get in. But certainly, you know, if this is an immediate concern, your brother-in-law is calling you, they're in severe pain, maybe taking him to the emergency room may be the better answer. And again, it really depends on the diagnosis. So that's where I'm going to talk to you about what we may be seeing here. So the question that you would ask yourself is this a blood clot or is this heart disease of the leg? Now, it certainly could be other things, but I'm going to focus on these two diagnoses because these are those persistent symptoms that sometimes you don't necessarily pay attention to because you see some swelling and you say, okay, it's probably going to get better. But I would suggest that you do pay attention to this and take it quite seriously and address it in an urgent fashion. Because in fact, if it is a DVT, which is a deep venous thrombosis or a blockage in a vein, it will appear as swelling and pain. And it may occur after something that we all do, which is take long trips or plane rides. And that is probably one of the biggest causes for deep venous thrombosis in someone who isn't undergoing surgery, because it can happen after surgery as well. And in fact, 45,000 Canadians per year develop DVTs. So it's certainly something that you want to be aware of. The other potential diagnosis here is that this gentleman may have heart disease of the leg. So we are all familiar with heart disease when it occurs in the arteries in the heart. But in fact, cardiovascular disease can occur in all of the vessels in the body. And this is when there's a blockage in an artery. There's blockage in the blood supply to the leg, and a patient may actually have pain that comes and goes in the calves with walking, even on flat ground. So how do you know that this is potentially what we're dealing with? Well, if a patient comes in and says to me, you know, I was walking up and down the block a couple years ago, and I had no problems doing that. But now I can't walk half a block without having to stop because I have so much pain in the back of my legs. That's a clue to me to say that we need to look at the vessels in those legs because there may be a decline in blood supply. So this is an example of a DVT, which is, again, a blockage in a vein. And on the left, you can actually see the anatomy as it comes through the body, the iliac vein, the femoral vein, into the popliteal veins that go into the back of the leg here. And here, there's a DVT. There's a big blood clot in the femoral vein. If that blood clot breaks off into little emboli, a patient can actually develop blood clots in their lungs, and that can certainly be life-threatening. The other thing that can happen is, aside from the blood clot breaking off, when we have a blockage here, we're not able to get this blood back up to the heart. So as a result, the leg swells. And I'll show you an example of what that looks like. Usually you're going to see it in the back of the leg as swelling, pain, warmth, and redness. These are the signs and symptoms of a deep venous thrombosis, or DVT. Another picture of the same concept of a DVT. And as you can see, there's a blood clot occurring higher up in the veins. And then you're going to see it as basically blood flow not being allowed to go back up to the heart. And so you end up with this swollen, red, hot leg. On the other hand, if we're talking about arterial disease, which is the heart disease of the leg that I'm describing, if you look on the left here, you're going to see that there's, over time, heart disease in these arteries, okay, or cardiovascular buildup of plaque in these arteries. And as a result, when we walk and we need more blood flow into these legs to be able to walk, if there's a blockage, we're not able to do it. So at rest, the patient's okay. The minute they start walking and they need more blood flow, there's a blockage. We're not able to get that blood flow where it needs to go, and it's going to manifest as pain with walking. What we're not going to necessarily see is swelling or warmth or redness, but we will see pain, or we'll hear about pain as a symptom. Sometimes the leg will feel cold, and it may even be, if it's bad enough, sometimes we'll see a decline in blood flow such that we can actually see purple toes or a darkening of the skin as opposed to redness. Okay, so we talked about persistent symptoms of the legs, and now we're going to talk about another persistent symptom. If we could have the next poll. So your husband is snoring. He has always snored, but he says he doesn't snore. He keeps you up most of the night with his snoring. Recently, his snoring has become much quieter and does not last as long, with lots of quiet breaks in between snores. A, you are relieved and move back into the bedroom. B, you tell him to get tested. C, you get him some breathe right strips. And D, you check his blood pressure. So answers are coming in slowly but surely. This is a pretty good medical class here. So 8 out of 10 of you suggest that he get tested, and 2 out of 10 suggest that he check his blood pressure. Okay, great. So you're on the right track for sure. And let me advance that slide. So certainly it's time to tell him to get a test. And perhaps some of you've already experienced it. A sleep apnea test basically is what we're talking about. Answer A, you're relieved and you move back into the bedroom. I put that there because a lot of times this is an ignored symptom. And it's sleep apnea, which is what we're talking about, obstructive sleep apnea, is often a silent disease. And it's often not talked about, and it's put up with. And that is certainly a lost opportunity to improve health. And C, I put in because some people feel that, well, if I just open up my upper airway and get some breathe right strips, it's going to make a big difference. Well, the reality is obstructive sleep apnea does have to do with the upper airway being closed off, but not due to the sinuses. So only if it is a sinus issue that's causing you to have trouble breathing will the breathe right strips help. And then lastly, check blood pressure. I put that in because, as you'll see, one of the side effects of sleep apnea when it is not treated can result in a lot of different side effects, but one of them is certainly hypertension or high blood pressure. So we'll talk a little bit about that. So just a diagram to, again, illustrate the concept. When one has obstructive sleep apnea, this is a person here laying down on their back. Air is supposed to come in through the upper airway and actually come down right into the lungs. But with obstructive sleep apnea, the upper airway and the tongue kind of fall back into the back of the nasopharynx here. And as a result, there's an obstruction. That's why we call it obstructive sleep apnea. There are different types of sleep apnea, but we're talking about obstructive sleep apnea. And the normal airway, one should have complete clear pathway there. So why do we care about sleep apnea? Why is snoring such a big deal? We hear people snoring all the time. Sometimes it's funny. People will see it in movies. The reality is it carries with it a lot of potential risks. Sleepiness, car accidents, falling asleep at the wheel, high blood pressure, heart failure, memory loss, dementia, weight gain, diabetes as a result, depression, and even sudden death can be associated with obstructive sleep apnea. And why the sleepiness? Well, the sleepiness is because if you don't get enough oxygen to your brain when you're sleeping, your brain actually wakes up. You don't realize you're waking up, but you're actually waking up, sort of micro awakenings that occur all through the night. And when we test you for sleep apnea, we can actually, through monitors and our diagnostic equipment, we're able to count how many times you're actually waking up without you realizing it. So imagine if you're having those little micro awakenings all night. You're going to wake up in the morning, not rested, exhausted, and that contributes to all of the things that we mentioned. There is treatment for sleep apnea, which I'm sure some of you are familiar with. Not necessarily the most comfortable, but certainly over time and with consistent use, as you reduce your fatigue and you have this oxygen device, basically keep your airway open, you get better rested, you're able to function better during the day. You can then work on weight loss and getting to a healthier weight, which then can often eliminate the obstructive sleep apnea. And now we're also talking, in addition to weight loss and the CPAP, which is the device I just showed you, some patients are candidates for surgery, but that's a very small number of patients. And there's a new device called an Excite OSA, which you can see in this picture, this gentleman is actually wearing it. And it's supposed to stimulate the muscles of the tongue to actually tighten those muscles up so that you don't develop obstructive sleep apnea. That's a relatively new therapy that's out there. In fact, they're advertising for it right now, and it's still very new. So something to think about for the future. So now you have some experience with some of the diagnoses of some medical conditions that we talked about. We talked about stroke under sudden symptoms. We talked about delirium under unexplained symptoms. We talked about persistent symptoms, leg pain due to arterial blockage and also due to venous blockage. And lastly, we talked about sleep apnea. And so I think I'm going to stop there and hand it over to Nazmulbai if there are any questions. And thank you for your time.
That's great. Bashir, do you want to take it from here? Okay, we'll get started. Right. Okay. So, is DVT permanent or can it be treated to remove the blockage?
Yeah. So, it depends on where the DVT is, and it depends on what else is going on with the patient. So, typically, what will happen is we'll treat with anticoagulation, and that blood clot will get reabsorbed by the body over time, and we can actually eliminate that blood clot. But it does take time, and it does take the use of anticoagulants. Rarely do we do surgery to address the vein issue because we have such good success with the anticoagulants. But again, it just depends on the patient's situation and how complex things are.
So the blockage is in the legs or wherever. How are they identified? Is it same as, blockages in the heart kind of thing?
Yeah, great question. So to diagnose a deep venous thrombosis, those who are, practicing medicine for quite a while, it's a very classic presentation often. But ultimately, to do a proper diagnosis, we use ultrasound.
All right. Okay, great. The next question is, should one sleep on the back or on the side?
Mm-hmm. Yeah.
Which is a better sleeping position?
Yeah. Different patients are going to want to sleep differently, and they're going to change their position during the night. Certainly, we know that if you're sleeping on your back and you have obstructive sleep apnea, that's where you're going to be at most risk for it. And so certainly when you sleep at your side, you're going to more often than not eliminate that obstruction from the back of the tongue. But, you know, that's not something that one can necessarily control. And so sometimes what we tell people is, even if you're wearing your CPAP device, if you can at least wear it for 4 or 5 hours during the night, then we can reduce your risk and at least get you a good 4 to 5 hours of consistent sleep with no obstruction, because we certainly can't control what position you sleep in.
Right, right. Now, I believe apart from the CPAP and all those machines, there's also something that one ties or puts on the back so you don't roll over or change your sleeping position while you're asleep. Is that something you come across? Or?
Yeah, I'm not familiar with that necessarily, but I suppose that would be helpful. I don't know how comfortable necessarily that would be. As it is, people complain a lot about the CPAP device itself. They have become better. They have become smaller. But positional changes certainly make a difference. I've even advised some patients at times to, if they can't use the CPAP for any reason, that even if they're propped up and they're able to get their daytime nap in a recliner where they're kind of sitting up, they're going to have at least a couple hours of some deeper sleep without the risk of obstruction, because they're not lying flat.
Excellent, excellent. Sleep medication, is that a good idea for sleep apnea or no?
Sleep medication as in something to put you to sleep?
Exactly, so you at least get a few hours good sleep.
Yeah, the reality is the more the deeper you sleep, and the use of sleep medications, those medications are going to relax your muscles even further. So while your brain is going to sleep, or at least you're going to feel that sleep, by relaxing those muscles with those sleep medications, you're actually increasing potentially the risk of the relaxation of the tongue into the back of the mouth, which actually makes sleep apnea even worse.
Right, so not a good idea.
So
okay.
It's kind of counterintuitive, but the reality is it's actually not considered standard of care to do that.
Okay, great. Can OSA happen to normal weight persons?
Yeah, that's a great question. So, you know, when we have people come into the office, a lot of times we can look at what we call body habitus, or the structure of a person's neck. And there are certain things that will make them more prone to developing obstructive sleep apnea. So sometimes we'll describe a short neck, for example. But typically, the majority of patients suffer from obstructive sleep apnea due to weight issues. But there's absolutely a small proportion of patients who, just based on their anatomy, are at risk for obstructive sleep apnea, even if they are normal weight. But they're definitely in the minority.
And snoring is not just a man's condition, right?
Absolutely. Yes, absolutely. I think in this vignette, I used a male, but absolutely can happen in females.
But more men than females?
Probably proportionately. I'm not familiar with the exact breakdown or numbers on that, but I think as we all, you know, as a Western society deal with obesity as an issue, it's a problem across the board, gender-wise.
No, it's just that women complain more, so that's why we feel that. Okay. Yes. I'll let that pass. Okay. He's taking 81 milligram for people with cholesterol as prevention considered controversial. Okay.
Yeah, for sure. For sure. You know, it's flip-flop a lot, even during from the time I trained to the time I practiced in the US to the time I practice here, as studies come out looking at the benefits and the risks of aspirin, we're always, it appears to our patients, we're always changing our mind on that recommendation. Certainly cholesterol is better addressed through the use of cholesterol medication, but aspirin as a cardiovascular preventative medication really depends on the patient's age and the patient's other medical complications. And what I mean by that is that, you know, if you ask me that question for someone who, and we're talking about 81 milligrams of aspirin, which is considered a preventative dose of aspirin. It depends if we're talking about primary prevention, meaning trying to prevent heart disease before it's actually present, versus secondary prevention, whereas we're trying to reduce the risk of another event after someone has already had and been diagnosed with cardiovascular disease. And then it also depends on the age of the patient. So a patient who's 85 may actually have more risk from the use of aspirin products versus someone who's 65. So that's a complex and very interesting question, because it depends on the patient we are talking about, their risk factors, their medical history, and their age. So.
Okay, there you go. Melatonin, a small amount, is it okay to have it regularly to improve your sleep?
Yeah, so there have been studies on melatonin. You know, it really, when it's been considered or recommended, has been one in smaller doses for short periods of time. And in fact, an article just recently came out that it really was meant to be used when people were changing time zones, when people were traveling, and then when they were trying to re-regulate their sleep-wake cycle because of travel. It really wasn't meant to be something that was used chronically in high doses. So I think, you know, if someone is struggling with sleep, there are sleep specialists that one can see, because I think the diagnosis of what the trouble is with sleep really should be addressed first before we start using medications to improve one's sleep, because we really have to understand, well, why do we not have good sleep? What is the issue? Is it a quality issue? Is it a quantity issue? Is it an underlying medical issue like obstructive sleep apnea or other issues? So I think just applying, you know, an over-the-counter aid like melatonin or any other over-the-counter aid, it's skipping steps, so to speak. So I would work on understanding the cause, the root cause first.
Got it. Are there any other questions? Anyone wants to ask questions personally? I mean, not through the chat. Anything else?
Hi, Nazmul, if you allow me.
I will, Dr. Najar Ali. I will, for sure. Go ahead.
I know I'm a very simple family physician up in the woods of Brampton, not on the same caliber as your speaker, but I mean, a few comments I would like to make, if I may, Zubina. Heart disease of the leg. Actually, it's the first time I heard that concept of heart disease in the leg. We just call it peripheral vascular disease. Yes. But that doesn't mean one thing or another. Actually, it's the first time I heard that. And the concept of the treatment with DVT, the way we have it in Canada anyway, it's sort of, if it's just simple DVT of the leg, a treatment anywhere between 6 months to 12 months, depending on how severe it is. And also there you have to realize that sometimes, not as often as, hopefully not as often, you can get also a concomitant pulmonary embolism with DVT, because the clot goes up in your lung vessels and all that, and you can give that. At that particular point, then the use of core anticoagulants is much more longer period than others. And there's also a third case where people keep on getting these DVTs on a constant basis, so chronic DVTs, if you want to call it, and or have multiple DVTs. I have one particular patient that has a clot in the mesenteric vein itself in the abdomen, and she's doomed to have coagulation for the rest of her life. So it's really very much dependent, and sort of don't dismiss it. I mean, it's very important that you treat it, and it's very important that you treat it for a minimum for 6 months, a minimum, and with the anticoagulants, and really, and you should seek the what do you call it, the doctor's advice in terms of that. You know, with regards to what do you call it, you mentioned about what is the say, aspirin. Yes, aspirin. As far as we're concerned in Canada, that aspirin is a no-no for anyone who does not have cardiovascular disease. Mm-hmm. And what do you call it? She alluded to what you call it. Our speaker alluded to the fact that it's been the use of aspirin has been up and down, and it's like a yo-yo. And more recently, is actually can be considered as malpractice if you use aspirin for someone who does not have any heart disease, because the complication of aspirin usage in terms of GI bleed is far greater than the what do you call it, and the outcome. Do you agree with that?
Yeah, I absolutely. And I alluded to the age really also being an issue, because you mentioned Dr. Najrali, and by the way, your reputation precedes you. So certainly not a simple,
doesn't think so anyway,
certainly you're not a simple practitioner up in Markham. What I would say is that, you know, the risk not only of GI bleeds, which is just catastrophic when it happens, but also of neurologic complications, right? So, you know, dealing with elderly patients and falls and head injuries and things like that. So yeah, absolutely appreciate your comments. And
the third one was regards to sleep apnea. I think it's very important, and really that one has a problem with the snoring, and that you should check the sleep studies and do it properly in a good lab. And that will give you a proper, and then have a consultation with the respirologists that do this type of work rather than going to us. I mean, because we actually, we fully fledged medical doctors, but we're not really specialists in that. But it can cause, sometimes it can be the cause for the coronary artery disease issues, heart attacks, and all this. There are other conditions that can reduce the what do you call it, the use of the CPAP, because it is very cumbersome to use it. There's no question at all. But you know, if you, one of the most important one is the weight loss. And I think in my practice, at least, I find that, you know. And the last one I wanted to say, the ratio from what I last heard is 70% men and 30% women.
Mm. Yeah, but we women are getting up there though, too.
I know.
It shouldn't be ignored in either gender.
You women should stop drinking and stop smoking.
Thank you for your comment.
Thank you.
Thank you, Dr. Najrali. That was great. Thank you. I don't see any more questions, but if I can ask, I don't know if it's possible, in general terms, when should, go ahead, who is this?
Shafiq.
Oh, Shafiq, go
yes,
ahead.
I would like to make a personal comment here. I was not overweight, and I used to snore heavily until sometimes my wife used to move in another room. When I went for my checkup, the doctor told me, he said, well, ask your wife, would you like to have a snoring husband beside you or no husband at all? But this was a joke, and he sent me for a test. Doctor, I was not overweight, no smoker, nothing. Mm-hmm. But they found out that I stopped 42 times in a minute.
Yes.
Yeah, and I never realized it, but my wife used to wake me up and said, turn on the side. And this was about 20 years ago. And they found that I was not overweight, but I used to be so relaxed when I used to go to sleep that the valves or whatever it is, it closed up. And I started using CPAP 20 years ago with the big sized CPAP, and now I'm on the small. But I'm telling you, if you have that problem, you better have a CPAP. I know in the beginning, you might find it clumsy up your face. I just use those two pillows in my nose, and it's working so well that it's like my first wife. First thing when we travel, it's my CPAP, then the rest. And it really helps. Although when I wasn't using CPAP, I never felt tired in the afternoon or anything. I was perfectly fine. I would be active all day. And the doctor couldn't decide what was wrong with me. But I said, if I have to use it, I'll use it. And I'm telling you, that is the best thing ever happened to me. And my wife is back in the room as well, long time ago. Thank you. Just
Wonderful.
wanted to let you know that I was not even overweight.
Excellent.
That's an excellent story. Thank you for sharing that. It really just underlies what I talked about the number of times your brain is waking up at night without you realizing. So for you, it was 42. I've had patients that it's been 90 times a night over an 8-hour sleep period. So you can imagine this person's brain is getting absolutely no rest whatsoever. Thank you.
Now, sorry, to add it up here, as soon as I put on my CPAP, and the next 2 minutes, I'm gone.
Yeah.
I sleep through straight 7 hours. No disturbance, nothing at night. Even the lights on in my room won't bother me. I'm gone. And that is the best thing, 2 minutes maximum.
Wonderful, wonderful. Shafiq.
Yeah.
It probably runs in the family, right? Snoring.
Yes, my brother Mustafa is using it as well because he's using it for different purpose. I'm the one who told him to start using it.
Shafiq's brother is my brother-in-law, so I can afford to.
Which side of the family is running?
My brother-in-law Habib is using it as well. Habib Dala.
Oh, he's in the audience. Oh, well done. Well done.
Yeah.
So I was right. It runs in the family, right?
Yeah.
Okay.
Well, you might as well get one as well, Nazmu.
What do you know about my lifestyle?
Thank you.
Okay. All right. So I was asking you, are there any general guidelines as to when one should go to emergency or seek urgent medical help? Or is that too vast a subject to cover?
Yeah, I think, it's certainly been a challenge with COVID as well, because I think some of the answer to those questions, and that's why, the answers to those questions weren't hard and fast, at least not all of them. Certainly the stroke one was, there's no question, dial 911. The other ones somewhat depend on how quickly you can get in touch with your doctor, how quickly they're able to get that diagnostic testing done for you. And that's somewhat different for different people in different areas, and certainly in different provinces, and certainly in different countries, right? So if one can contact one's physician and they're pretty confident that they're able to get in touch with them in a reasonable amount of time, meaning that day, that's one thing. But if one can't, the emergency room can often be life-saving. So I'll give you a very short example. A previous speaker talked a little bit about his experience with sleep apnea and didn't ignore it. But, I've had a situation where, if we talk about the stroke situation, where, a female patient woke up in the morning, was feeling okay, got in the car to drive to work, and her right leg wasn't working. So she wasn't able to press the accelerator. And so didn't really think much of it. She was in her late 40s, didn't really think much of it. So just used her left leg and drove to work. and decided to spend the whole day at work, came home at the end of the day, and then happened to mention to their family members that, you know, interestingly, my right leg really wasn't working this morning. And in fact, an MRI later showed that in fact she had a stroke, right? So those are situations where, you know, time is of the essence. And if there's a delay, then sometimes the emergency room, while yes, you may spend many hours there, but you're going to be in a safe setting and you'll get the diagnostic testing that needs to happen. But, you know, as much as possible, you do want to go through your primary care physician first. So making that call and, you know, simultaneously, depending on the urgency of the situation, you may be doing both things. And that's why some of those questions, some of those answers, you're actually doing 2 or 3 things at the same time, right? You are calling that person's family member. You are calling 911. You are calling the physician, because you need to get all of that information ready to go to the next step, whatever that is. And calling the family member and getting family history and information is also very, very important. So these are not exclusive answers. I guess that's the best answer I can give you without.
No, that's great. That's great. So apart from your case studies, you know, we discussed, are there any general guidelines as to when to go to emerge? I know, for example, for heart, they used to advertise, you know, if in doubt, just call or go to emerge, call 911, right? Anything to do with heart. So apart from heart, is there any other conditions where, you know, one should really take extra steps?
Yeah, well, I guess I would put it in the framework of, you know, ABC, right? So airway, breathing, circulation. So, you know, start with something basic like that and say, you know, if someone's having trouble breathing, if someone's having trouble not able to, you know, either having chest pain or having the neurologic symptoms that I talked about with stroke. I think any of those big areas are enough to warrant a call to 911. I think if something is a little less urgent and is a symptom that's developed, you know, over several hours and is not you know, scary. I mean, sometimes use your fear to say this doesn't look right. You know, the lady with the delirium, that's not the way she was behaving an hour earlier, right? That's an acute change. We call it an acute change. So something that's sudden is enough of a reason to say, okay, I probably want to get help here. And maybe it's not 911 as your first call. Maybe it is a call to the doctor's office. They're trained there, and their triage staff and their nurses are trained there to also give you that guidance, because maybe you don't know, and that's okay not to know. It's okay to be able to say, all right, well, maybe I don't feel comfortable dialing 911 yet. Let me first get one more piece of information, and that's through your doctor's office. That's okay to do. But again, airway, breathing, circulation, any of those things, right? If someone's having issues with breathing and it's an acute issue and they're short of breath acutely, you don't have time to necessarily call the doctor's office and wait for a call back. That's something urgent.
Sorry, can I?
Oh, yeah.
Please.
Okay, let me tell you a story, which is a true story that happened in Masumin. At one time, we were sort of gathering through some kind of event there, and one of the gentlemen was sort of apart from fasting, which was not Ramzan time. He was doing sort of non-Wajib fasting with us, sort of, and at the same time, he sat there, and it was a long fast, and he sat there and started praying Surah Yasin and everything else, no? So we're kind of wondering how. I was just looking at him, and sort of somehow I saw him going through the process of kind of not taking deep breaths and everything else, not being quite himself, as you said, you know, Zubina, many times it's just recognition of these things, and sometimes it's very more important. Yeah. And I sort of told him I asked him, okay, let's take him up to the room. He was taken to the room, and this also comes with the use of aspirin, you said. We were looking for 2 aspirins, but we find anybody who had some aspirins. We managed to get 2 people there with 2 aspirin, told him, gave it to him, asked him to chew it, and we called an ambulance straight away. And I knew he was having some kind of a heart disease for sure. So we called an ambulance, and as soon as he did that, we called up an emergency and asked him to take him to cardiac unit, because that was really, the suspicious level was extremely high. And he was found to have a blockage, and he had a stent, and mashallah, it was much better now. He did say thank you to me, but he did say that, which is Islamic way of doing things.
Yeah. I think that's an excellent example. Yeah.
The other example, let me give an anecdotal example. This is more or less, it sounds like a joke, but it's not. It's a true story. I mean, we in family practice, we get all these people, a very, very, very heavy sort of man, and who had a quite severe problem with his snoring, refused to take CPAP completely, and he refused to go to sleep studies. He just refused. So 3 wives later, he found a wife where he actually managed to stay with her for a longer period of time. She was deaf. So moral of the story, if you have snoring issues and your wife can't tolerate it, just find yourself a deaf wife, you'll be all right. Anyway, this is a joke.
On that note, not a real case study. Okay. But
no, there was real cases. I don't joke like this.
Come on,
I joke about everything except medicine.
I know you better than that. You can make
I know that's the problem, I think.
Okay, wonderful. Okay, right. Thank you so much, Dr. Mawji. That was excellent. We had a good discussion, good case studies, and thank you, participants, for relating or relaying your stories and your cases. Really very informative, and I hope we all learned something. Signs to recognize and what not to ignore.